Is joining us from Montana. She is our VP of Medical Billing Services. And I asked her to be present for our general care management session because I only know enough about billing to be dangerous, and she is our expert, and I wanted her to be present to address at least the questions that could come from this presentation. My goal is to look at this from three fronts. We're going to talk about it from operations, implementation of chronic care management or other care management services. We're going to look at it from a policy standpoint, and then also the update that came out with the G0511 ability to bill multiple in 1 month. From a billing standpoint, how to accomplish that. So the first thing that happened is 2024, the physician fee schedule came out, and there were some changes within that document. There is an updated MLN Matters from CMS, and you can find the link here that will take you directly to that document. There are new provider types added to that will help expand services within your clinic. And then we also got in some more information and clarification regarding the billing of these types of codes and services. There was also a webinar that was provided by RHI Hub, and I wanted to give you the link directly to the slide so that you can review that at your leisure to go into more of the detail of what we're covering today. So what was added? This language is pulled directly from that MLN Matters. These are the changes that took place in the 2024 physician fee schedule. Marriage and family therapists and mental health counselors were added as practitioners for the RHC. Remote, I'm not going to try to pronounce all of that. RPM, RTM, PIN, and CHI were all added as additional services. Intensive outpatient program services were added, and I know Jill has talked about that and being a great resource for our patients. The all-inclusive rate, of course, was updated within this year. Social determinants of health, that is going to be a broader and broader topic that we need to talk about. It's going to become rising in awareness over the next few years, and is going to become more and more important for the RHC. And then what we want to talk about today is that table of general care management services codes, and then of course some additional services there as well. On the screen are the definitions of what qualifies for the marriage and family therapist and the mental health professional. I know it's very small font. You will have, I believe everyone's going to be given access to these slides. I didn't want to create 3 slides for each definition, so it's on the slide. It's essentially going to be based on your state of how they qualify. So if you're adding mental health services to your clinic and you struggle to find an LCSW or those that were already on the list previously and you want to expand who your providers are, these are the definitions of how they would qualify. So looking at the codes, you have the breakdown of the different types of general care management codes and their relevant code number. That's as detailed as I can get. Julie, do you have any further detail on this slide?
Not really, until, people have questions, we can go there.
All right, thank you. It's fun having her here from Montana. We don't get to talk. Now, the main detail I wanted to bring out is that in order to be able to bill a code, you have to meet all of the requirements. And so that's what this slide goes into, is the detail of the amount of time, the service provided, all of that, of how to actually qualify to bill that code. And there are, she has a little bit more detail about an RHC may bill his HCPCS code G0511 multiple times in a calendar month, as long as all requirements are met and there's no double counting. 2024 reimbursement is $72.98. And one note to make is that copay and deductible do apply to each instance it is billed. So that needs to be very clearly defined to the patient so there isn't any surprises.
Just to jump in here real quick. So yes, if you're planning on doing multiple of these codes, you need to make sure your, for instance, 20 minutes for your BHI does not include anything from your principal care management time for 30 minutes. So in your visit note, you have to mark, if you only have one visit note, which is what most clinics are doing, document the date and the start and stop time and then how many minutes. And then once you reach your 20 minutes or 30 minutes or whatever, then you can go ahead and bill out that G0511. But if you get audited, you need to be able to show, yes, I was able to bill 3 or 4 of these codes, and this is the visit note it goes back to, and the time doesn't overlap.
Julie, quick question, this is Joe. Is that the same with CCM and RPM? We know, of course, chronic care management and RPM often go hand in hand in terms of coordinating services, but can they both be billed in the same month as long as they don't duplicate the time of service provided to the patient?
Can you go to the next slide?
Oh,
Okay, so RPM and our RTM are also billed with the G511. So again, they can be billed in the same month, except these two sets of codes are mutually exclusive. So you can't do in the same month RPM as RTM, but you can do RPM and the previous slide, or RTM and the previous slide. Does that make sense?
so RPM and CCM.
We're both.
Well,
on
it's
the
all, they've got away
Yeah.
with CCM. It's,
Yeah, it's G0511.
yeah, because of all of the different codes that you're doing. So yes, you can do something from that first set that's on the screen right now and the previous screen, or you can do the bottom set and the previous. You just can't do the two
Oh.
sets that are on this screen together.
So you can't do RPM and RTM in the same and bill them as separate visits?
Correct. You cannot do them in the same month.
Yes, Keisha.
What is the equipment requirements to bill RPM? For example, can a CGM be counted for the RPM, continuous glucose monitor?
I don't have details on the equipment requirements for each of these services. It's more of the billing aspect of it,
I
of what.
looked in, the AMA book too, the coding book, and there's nothing specific in there.
So the question is what equipment you have to have.
Yeah, like, can we do this? We have a lot of patients that have CGMs and we are receiving that data. And is this something we can be billing for using that?
Under the RPM code,
Yes.
which is G0511.
So later in the session, I have a FAQ. I interviewed a manager of a clinic who does both CCM and RPM.
Okay.
And she said if we had questions regarding implementation of those services, that I could reach out. She gave me some great insights of some of the struggle areas that they had while they were putting this practice into place.
Okay.
She talked about having the equipment mailed to the clinic and having that, trying to coordinate that with the patient. And then the quality aspect of making sure they're getting accurate reads with that equipment. But I think that that's another question that we could bring to her to get some more operational feedback of what equipment qualifies for the RPM services.
Thank you.
Quick question to the audience, at least here in person and online. How many are billing more than one G0511 in a month? See one hand, two hands. If it's yes, go ahead and put that in the chat. It'd be good to know in terms of how that's working, if you're getting denials, et cetera. Something that we certainly want to take advantage of in terms of billing for the services that you're actually providing.
Thank you. And then, of course, you have your psychiatric chronic care management as well. So there's some details about what you have to have within your records to be able to qualify to bill for that type of service.
Sorry, can I ask one more question?
Yes.
While we're on the RPM. So are RPM and RTM the only two from this, from the chart on pages 9 and 10 of the MLN matters that cannot be billed in the same month? So like we could bill, the PIN and CCM or any other two?
Yes, that's correct. It just states that the RPM and RTM are mutual exclusive, so you can't do the same, you can't do them both in the same month.
Thank you.
And this is why I have her present, because she's
Perfect.
amazing. Thank you, Julie.
Thanks, Tressa. Just to go back one slide.
Yes.
The psychiatric chronic care management, this just happens to be a group approach. So it's similar to BHI, where you'd bill under the G0511, But with this, you need to have a primary care provider, your RHC provider, a healthcare manager, and there is a definition there for you. And you also have to have a psychiatric consultant able to give consults. They don't have to actually see the patient or prescribe, but you have to have all three members of that group in order to build a G511 or 512. That's it.
Any other questions regarding these few slides on the billing aspect? We'll hold and have Julie stay on just in case any more billing questions come up, but I do want to move into some considerations as you consider implementing these services. So I work in policy. That's my whole world. I develop policies and emergency plans for clinics. I dream in policy numbers. So as you implement new services, don't forget to build the framework, the support network of how you accomplish those tasks. So really making sure that as you're bringing new things in for your patients, that's great for their access of care and supporting them and eliminating some of that overutilization of services, but also supporting and putting that framework of how are we going to accomplish this task? And that's where policy development comes in. So as you're looking at any of these types of care management services, this was just a basic outline I wanted to provide to you as you consider developing policies for these service lines within your clinic. Looking at your definitions of what each term means, your procedures, the provider will, the staff will, what are the expectations for the different roles within the clinic? Your consent process, especially if a lot of this is online, what is your consent to treat? How do you obtain that? What is the expectation for that? What are the expectations within the medical record to not just meet the 49110, but also to meet the billing coding requirements and building your templates accordingly and supporting that in policy for here's the expectation of what will be captured in every medical record. And then what are the care plan requirements based on the set out outline of what you have to capture. Some additional reasons clinics put this service into place is it really does benefit your patient. It improves their overall quality of care. It prevents overutilization of your services as well as ER visits. It reduces hospitalizations and it encourages patient engagement. They take an active role in their care plan. And then some of the staffing struggles we find is there are great outsourced care management services that you can engage with if you are struggling to maintain the appropriate staffing levels to provide the service in-house. So there's different elements that you have to consider as you start the service at your clinic. One of the biggest considerations, of course, being staffing. And then, of course, it really depends on your volume of services. I had one clinic say, well, we were able to show financial viability on why we were hiring that RN for that service because we did time studies of how much time was being captured with that patient from coming to the clinic so often. And then having that dedicated staff member to provide those services allowed them to grow that service area within the clinic, and they were paying for themselves within a very short amount of time. So there's ways to accomplish the task in-house, but it does take some process of being able to convince everyone that it's a viable service. Patient education is huge when it comes to starting a new service line, especially care management. They need to understand what the service is, how it impacts them, what their access to care really is, what that looks like, how to address and communicate, the sharing of information across the team, how that happens, the transparency of the cost with that deductible being included, and then how to enroll and how they get revoked from that service. So, or how they can revoke that service. So staff education and patient education is very important as you consider implementing this service. Medical records, as Julie mentioned, you really need to keep very strict track of those time elements to be able to show that you're able to bill for multiple times a month. So documentation is key, but also working with your vendor ahead of time as you start this service to build your templates so that you can easily track that and there's no guessing within that. And then costs, I took this slide from Julie Quinn because I am not a cost report guru at all. That is her world. And so I asked her permission to use this slide as well. And so as you think about adding a service line, just remember that care management services are considered non-RHC as they are paid outside the all-inclusive rate. You need to capture overhead if it's done in-house, and then it's completely removed if it is outsourced. In-house services, you would reclassify the cost, and direct cost would go to the non-RHC cost center. There is a link to the FAQ because we're running short on time.
We're good. We got 10 minutes before our next presentation.
So what I did is there is an office manager, her first name is Danielle, she lives in Florida. And I found out that they do care management services. They do both CCM and RPM. And in my mind, I think the most practical tool for you is what were some of the things that were struggles? What were some of the things that caused hiccups? What considerations should we have as we start these services within the clinic? And so I know this is very small font, but she gave some great insight. And again, she said that she's more than willing to ask or answer additional questions if you have them as we go through our process together. But she said, what was the benefit? And it's really the good outweighs the bad was her very first statement to me. And she said, it gives your patients quality of care and you're able to care for the whole patient. And that just settled in my soul a little bit because that's our intention, right? It's all about giving access to care and making sure that we're keeping our patients within their scope and making sure that we're following up with them on a consistent basis. The patients seemed more willing to share information when they were on their home turf. So connecting with their care management caseworker allowed them to share more detail and get more clarification on their care needs. Better quality of care, so the follow-up and continuity of care was more robust and documented, and they were able to show the ongoing communication thread with the patient. And then keeping information current in the patient's medical record. So the care management service they found was actually keeping current better on the insurance, on contact information, because they were keeping the system updated along with the clinic access as well. So that was another additional bonus of starting the service. And then, of course, the additional revenue, but she really wanted to make sure I put that at the end of that list. Because the goal really is to care for the whole patient. What were some educational items that you found helpful? And she said that staff really needed to be educated on how to identify who would qualify for the care management service to start that enrollment process. So helping them identify what the requirements are and if it would make sense for them to enroll in the care management service. And that was a staff educational process. They also had to work with the front desk for scheduling and clinical support staff and providers to make sure everybody was working together within that. Records need to be kept current because what they found is the care manager would go into the patient's file. Information was not current, and so they didn't have a current consent to treat, and the care management team had to take up and pick up and do all of the things. Costs of the service need to be transparent and discuss with the patients how their specific insurance handled the service. So because it could differentiate from payer to payer. And then what questions do you commonly receive from your patient? And she said, who's this person calling me?
Yeah.
And she said, one of the other things that they noticed is that the staff didn't always know who the care management person was. So the patient would call and say, Julie was helping me with this situation, and the clinic had no idea who Julie was, but it was their care management team. So really having great communication lines between, especially if you outsource, between the clinic, patient, and the care management team to know everybody's working together and who they're talking about. Another question they were asking is, what is this 800 number calling me? What is this number? So these are questions that they were getting. Why am I getting this bill? They weren't understanding of that copay requirement and deductible. And I believe on the slide that Julie provided for us, that applies to every time you bill that G0511. So really making sure that if they're participating in multiple versions of care management, they understand the implications of that. And then I did ask, why did you outsource? And she said it was staffing. They couldn't bring in the staffing at the clinic because it was a very small 3-exam room clinic. They didn't have the staffing to be able to do that. What were some of the struggle areas? And the biggest one, she said, was communication threads between the care management team and the clinical team. Who does the care team contact at the clinic if they need to make space for an appointment? Who does the clinic contact if they need information for a patient that has an upcoming appointment? So what are those communication threads, and really defining that out and having it written down? Knowing the care team well enough that the clinic can handle patient calls. That goes back to that story we shared. Handling the delivery of supplies. So this was specific to the RPM service, to the patient. relating to their care plan. So she said, i.e. blood pressure machine, et cetera, for the patient to use at home. And then one thing that she pointed out was that the care management team, if it was outsourced, doesn't mean they're local to the area. So if the patient had social determinant of health issues and they needed some connections with local services, making sure the care management team knew that list of resources, such as the food bank or other elements, to address the whole patient. Oops, sorry. What recommendations would you have for the clinics that are looking to start this service? Pros obviously far outweigh the cons. Dedicate a team member to be the liaison between the care management and the clinical staff. During a patient visit at the clinic, do controls on the equipment they're using at home to make sure they're getting accurate reads. And then working with the care team to ensure they understand the workflow of the clinic. She really wanted to know that these are our scheduling blocks and don't block 3 of them for this type of visit, and making sure that they worked with the care management team and the clinical staff team of how to schedule and how it worked within the workflows of the facility. So I thought she gave some great insight of some of the struggles, some of the practical steps of starting this process. And she did say if you had additional questions that you are welcome to reach out to her as well. Questions on this document? I'm talking very fast because we need time. Were there other questions in relation to any of the billing aspects, implementing the service, policy development?
Julie is still online, so if you guys have questions with regards to that, we still have the expert available.
Yep, still here.
Thank you, Julie. I appreciate you.
Mhm.
We're just checking to see if there's any questions in the chat.
No, must be no one.
All right.
Well, thank you, Julie, for joining us and making yourself available